rehab. Welcome, sir. Dr. Parthapratim is the professor and HOD of PMR in North Bengal Medical College, Siliguri.
Hello. Hello.
वहाँ कोई लड़का कोई है ही नहीं है, तो चुनाव वाले मतलब डिस्टर्ब नहीं करना है ना, चुनाव वाले नहीं हटा सकता।
Yes, still it's good morning. Thanks and regards to the IMS Raipur PMR team and particularly Jaydeep for organizing such a wonderful CME and also inviting me, and my deep respect to all the delegates. My topic is spondyloarthropathy and update. The thing is update means it's a update because every time that scenario is being changed, the nomenclature, the classification criteria, the algorithms, all are being changed every few years. So we have to be keep ourselves updated. And initially it was thought that it's a part of rheumatoid arthritis only. So Bloomberg in 1957 coined the term rheumatoid spondylitis. That was definitely a misnomer. And then for many decades, another terminology was in vogue, that is, it was called seronegative spondyloarthropathy, depending upon that source, rheumatoid factors negative and also ANA negative. But now it's called only spondyloarthropathy or spondyloarthritis. Spondylo means vertebral, and it's a family of inflammatory rheumatic diseases that share distinctive clinical and radiographic and also genetic features, with a preferential involvement of the spine and the root joints. Root joints mean the SI joints, hip joints and the shoulder joints. These are the root joints. And regarding the typings, many types came and went out also, and now these updated typings, ankylosing spondylitis, enteropathic arthritis, psoriatic arthropathy, reactive undifferentiated spondyloarthropathy, and juvenile spondyloarthropathy. Regarding the reactive, many people still call it reiters, but reiters is only 1/3 of the patients have reiters of reactive arthritis. They have classical criteria of conjunctivitis, urethritis, and arthritis, but all reactive arthritis are not reiters. And Behçet is already out because Behçet is completely a different diagnosis. Mostly comes under vasculitis. But this another way of typing is it's classifying both, because this typing helps in treatment protocol, planning. This axial spondyloarthropathy and peripheral. And axial is also classified into non-radiographic, radiographic. Non-radiographic means not comes in X-ray, but it may come in MRI. It may come in MRI, not always in MRI. Non-radiographic is depending upon the X-ray. No sacroiliitis in X-ray, it's non-radiographic axial spondyloarthropathy and also radiographic. And peripheral spondyloarthritis. Peripheral spondyloarthritis mostly psoriatic, reactive, undifferentiated and IBD associated. They involve mostly the peripheral joints. And the peripheral joints are mostly the lower limbs and large joints. Some epidemiology, prevalence 1.2 to 1.6% in worldwide, but in Southeast Asia it's less, 0.2%. And in India, spondyloarthritis AS is 7 to 9 among 10,000 population, and it's but it's still second most common inflammatory arthritis after rheumatoid arthritis. Male female 3.75:1. Men with AS have more severe disease, and peripheral involvement up to 64%. And its genetics is important because monozygotic twins have 63% and first degree relatives have 8.2%. So genetics, HLA between 90% is associated with HLA, so 10% is not associated with HLA. So HLA negativity does not rule out spondyloarthropathy. And it has been shown that HLA-04 is common in Asian, 5 in Caucasian, and 2 in Mediterranean population. And some non-HLA genes like ERAP1, CARD9, TLR7, and ILR, interleukin associated 17 and 23 associated genes are also associated with spondyloarthritis. And very important, gut dysbiosis plays a major role by activating Th17 cells, which act locally and in the gut and then systematically cause the phenotype changes. And biomechanical stress plays a role in the genesis of enthesitis. That is important for us physiatrists because if we can reduce the load on the spine, then the chance of enthesitis becomes less. Okay. And the basics of pathology: inflammation. There is inflammation causes sacroiliitis, spondylitis, spondylodiscitis, arthritis, and enthesitis. Osteodestruction, that causes erosive changes in predominantly root joints like hip, shoulders, and also in peripheral joints. Osteoproliferation, syndesmophyte discs and spinal ligament calcification, and bony bridging with ankylosis, ultimately leading to ankylosis. And for PG students particularly, there is a confusion between the diagnostic and classification criteria. We don't depend upon the diagnostic classification criteria for our day-to-day practice. Classification criteria is for research only, and for applied to patient groups, and they have high specificity. And in classification criteria, it is dichotomous. Either you have or you don't have. But in clinics, you may have. We can say you may have spondyloarthropathy, and it's depending upon some diagnostic criteria, not always criteria, diagnostic assumptions also applied to individuals, make a diagnosis, and it should be highly sensitive. And assessment of spondyloarthropathy, International Society (ASAS) now have given this is classification criteria, not diagnostic criteria, for axial spondyloarthropathy, which have sacroiliitis or imaging, and one or more features among this, like IBD, arthritis, enthesitis, uveitis, dactylitis, like this, and or HLA-B27 positivity has also been included with two or more features like this, sacroiliitis in imaging, in MRI also, and definite radiographic sacroiliitis according to modified New York criteria. And peripheral assess criteria for the peripheral spondyloarthropathy, arthritis or enthesitis or dactylitis plus one or plus two things on left and right table. That also includes HLA-B27 positivity and uveitis, sacroiliitis in MRI, or plus 2 in arthritis, enthesitis, dactylitis, inflammatory back pain in the past, positive family history is also included. And for diagnostic criteria, there is no single laboratory histopathological imaging features which is considered gold standard. So we can't say that still our diagnosis of spondyloarthropathy is mostly clinical, and so we can corroborate ourselves with the lab and imaging findings. So what are the clinical features? Inflammatory back pain, axial or root joint involvement, as I said, root joints, SI joints, shoulder joints and hip joints. Peripheral arthritis, mostly asymmetrical oligoarthritis in the lower limb, and arthritis mutilans, destructive arthritis, particularly in psoriatic arthropathy. Enthesitis, most common in Achilles and plantar fascia. Dactylitis causes sausage disease more in psoriatic arthropathy. Toes are involved more than fingers. Spine in atlantoaxial subluxation can occur up to 2%, and so full flexion and full extension lateral X-ray in every spondyloarthropathy patient who are complaining with neck pain should be done. And if the diameter is more than, if the distance between the atlas and the dental process is more than 3 millimeter, it should be cautious. And so if it is more than 8 millimeter, then there is surgical need. And there are many extra-articular features, but I am first going to what is inflammatory back pain. Everyone of you know it, but still I am repeating: age of onset less than 40, insidious onset, improvement with exercise, no improvement with rest, and pain at night with improvement upon getting up. What are the most common extra-articular? Eye is involved in most cases, 30 to 40%, and in spondyloarthropathy, unilateral, intermittent, alternating, non-granulomatous ocular pain with photophobia, redness, blood vision, and lacrimation. And if not treated, it may cause hypopyon and even cataract formation and even blindness. Cutaneous, in psoriatic arthropathy, there are many cutaneous features and reactive arthritis also, and GI involvement in mostly in IBD, but also in other spondyloarthropathy patients may have GI symptoms. Cardiac causes ischemic heart disease, aortic regurgitation, aortic stenosis, and conduction abnormality, and in lung it can cross pleural thickening, apical fibrosis, and restrictive lung disease. In renal features, secondary amyloidosis, IgA nephropathy, and NSAID-induced interstitial nephritis. Low BMD, though the X-ray features shows more white than normal X-ray, but the BMD is low. And DEXA should be done in lateral position, and it should be corroborated with other things. But more 50% cases they have low BMD, and that can lead to vertebral fractures. That should be given importance with all of our osteoporosis treatment protocol. And sacroiliitis is the hallmark of AS, and symmetrical syndesmophyte, bamboo spine, and dagger spine. These are the sacroiliitis. Okay. So the sacroiliitis initially is suspicious, grade 1, grade 2 there is some erosions, and grade 3 there is definite erosion, and grade 4 there is ankylosis. And this bamboo spine due to formation of syndesmophytes and ligamental calcifications, and dagger sign due to supraspinatus and infraspinatus ligament calcification seen in epiview. And MRI, also CT scan is very good for erosive changes of erosive changes, to see the anatomical changes, and anatomical changes can be also seen by T1 weighted MRI and T2 weighted fat suppressed view, or short tau inversion recovery star view of fine inflammatory pathology, like bone marrow edema, seen in bone marrow edema in the left iliac side of the bone. And so, now in the management goal, symptomatic relief from pain, stiffness and fatigue, maintain best possible and functional capacity, prevent and management extra-articular complication, prevent spinal deformity, joint contraction and ankylosis, maintain acceptable quality of life, and we should target holistic rehabilitation. General principle, we have both pharmacological and non-pharmacological intervention technique. We should have multidisciplinary approach, because for psoriasis we need a dermatologist, for GI problem we need a gastroenterologist, and like this. And we have to always we have to target, identify the target, and we have plan our treatment as treat to target. And during treatment, we have to always remember the socio-economic cultural status, because in all rheumatological textbooks they are always saying TNF, PNF and TNF blockers, biologicals. But in our socio-economic status, it's not always possible to give so much of TNF. And also considering the high amount of prevalent tuberculosis in India, we have to consider that thing. So socio-economic cultural status we should always remember, and we should use disease activity indices. Disease activity indices, there are varieties of disease activity indices. Bath ankylosing spondylitis disease activity indices, with NRS score 0 to 10 or BAS 0 to 10, with components like back pain, fatigue, pain and swelling in peripheral joints, localized tenderness, duration of morning stiffness and severity of morning stiffness. And if it is more than 4, it indicates active disease. As does ankylosing spondylitis disease activity score. These are the components which includes either as the CRP or as the ESR, and if there is a like -28 scoring system, and a calculator -28 scoring calculator as in RA. In spondyloarthropathy, this scoring there is a particular calculator, and if it is less than 1.3, it's inactive. Less than 2.3, low disease activity, 2.1, and if more than 3.5, it's very severe disease. Bath ankylosing spondylitis metrology index, which measures the triggers to wall, lumbar flexion, cervical rotation, lumbar side flexion, intermalleolar distance. And BAS 5 for us very much important, daily functional indexes, which this still is it's Western standard. We should make our own BAS 5. Starting with putting of socks, but most of our Indian people don't wear socks. And biomarker for disease activity indexes, ESR, CRP, very much important for acute fast reactants. Newer molecule is serum bisphatin, which are promising biomarker for spondyloarthropathy. And what are the pharmacological options? We have NSAIDs, corticosteroid, conventional synthetic DMRD, newer JAK molecule, newer small molecule like JAK inhibitors, and biological response modifiers, and with that biosimilars also. And what is the algorithm? Start with NSAID, if required glucocorticoid for short term and intraarticular, and after that low dose of sulfasalazine and methotrexate or tofacitinib, and after that we can add biologicals, TNF blockers, and we can switch over to one TNF to another TNF, and if TNF blockers does not work well, then we can go to the interleukin 17 blockers, IL-17 blocker like secukinumab. And instead, always first line of therapy, there is a debate regarding the continuous use and on demand, because there are many studies showed that continuous use of NSAID reduce the chance of skeletal deformities and inflammation. But considering the side effect profile, we use mostly on demand and up to 2 to 4 weeks only. And COX-2 inhibitors are safer, like etocoxib, and naproxen and indomethacin are good. One time you can give it a single daily dose also, sustained release dose. Corticosteroid has very limited role than in RA, rheumatoid arthritis or SLE or connective tissue disorder, but in spondyloarthropathy you can use only in the initial period to reduce the acute fast reactants, acute inflammation, and we can give intra-articular triamcinolone, intra-articular steroid to any joint, even in a controlled patient with a particular SI joint in pain, we can give serum guided or USG guided even. We can give triamcinolone or there is a one triamcinolone hexacetonide that acts longer. And regarding the synthetic derivative, I am not going into details. Just I am giving the in brief. You know everything. But methotrexate don't have any role in the axial arthritis, axial spondyloarthropathy. They may have roles. They have role in peripheral arthritis and definitely in uveitis. And leflunomide has also role in peripheral arthritis. Sulfasalazine axial role is doubted, and most of the Western studies don't allow sulfasalazine. But some Indian studies shows that sulfasalazine long term has definite role in axial spondyloarthropathy. So for our poor men, for sulfasalazine to start with 500 mg twice a daily to 1 mg thrice a daily, we can give jolly well, and definitely whatever evidence shows our clinically sulfasalazine do well. And TNF inhibitors definitely have role, and IL-17 blockers have good role. What are the TNF blockers? Anti-TNF monoclonal antibodies, infliximab, adalimumab, and golimumab, and P75 soluble receptor construct is etanercept, and pegylated Fab anti-TNF fragment is cetrulizumab. Is not available in India, but others are available in India. Dose in etanercept 50 mg subcutaneous weekly, infliximab 5 mg IV per kg IV. 0, 2 and 6 weeks. Infliximab is the drug of choice, and biosimilar, from my personal experience, biosimilar of infliximab do wonderful, and it's very lower cost than original infliximab, and it should be always thought as a first line drug, infliximab. And we can't continuously give every 8 weeks or 6 weeks. But initial after giving 0 to and 6 weeks, we can give it every 6 months doses. It's our Indian protocol, no standardized Western protocol. And adalimumab 40 mg also do well. Golimumab 50 mg every 4 weeks. Cetrulizumab is not available. But IL-17 blockers, particularly secukinumab, we have good evidence, good experience with secukinumab. It works good, 150 mg to 300 mg twice bi-monthly doses, and isaacsumab and brodalumab, and IL-23 and 12 blocker ustekinumab is also available. And now the newer drug tofacitinib, it's JAK inhibitors. JAK kinase have a role in initiating the inflammation and developing of pro-inflammatory cytokines. JAK inhibitors, tofacitinib, piglotinib have role in, and tofacitinib is now randomly being used, but you should be very cautious regarding it. It has a superior efficacy. It improves the quality of life. With methotrexate it can be given, and it even sometimes it works better than TNF also, and TNF blocker also, and has beneficial effect on reducing radiographic progression, but should not be administered with known hypersensitivity or active TB and sepsis or opportunistic infection, pregnancy, lactation, and severe hepatic impairment. And there is surgery in case of advanced damage, particularly hip and knee, total hip and total knee arthroplasty. And correcting the thoracolumbar kyphotic deformities by different type of osteotomy, but that is definitely, this type of surgery are definitely very may lead to complications like neurodeficits, permanent neurodeficits. A brief idea about psoriatic arthropathy affects 7 to 42% with psoriasis. 85% psoriatic arthropathy ensures many years after skin involvement, but 5 to 10% psoriatic arthropathy may precede or concomitant. Equal in male and female, and commonly 30 to 50 years. Juvenile psoriatic arthritis also is documented, and mostly patients come with dactylitis and enthesitis, and particularly in quadriceps and patellar tendon, iliac crest, rotator cuff, epicondylitis of the elbow, and here USG is good diagnostic tool. And subtypes of DIP predominant 10%, symmetrical in 5 to 20 or asymmetrical 7 to 80%, axial predominant 5 to 20, and arthritis mutilans is rare. Hallmark sensititis, dactylitis or sausage. DIP, these are the pictures, DIP involvement, dactylitis, arthritis mutilans. And these are the psoriatic arthropathy X-ray, which shows all the features: ankylosis, subluxus and osteolysis, and classically pencil in cup deformity. And groups of drugs in psoriatic arthropathy, particularly we can use cyclosporine, azathioprine, tacrolimus and mycophenolate. And biologicals, apart from the TNF blockers, secukinumab and isatuximab, ustekinumab have a role. T-cell blocker have also role. And in psoriatic arthropathy, methotrexate has role in cutaneous and peripheral arthritis, not in enthesitis, all like lefunomide and sulfasalazine, but tofacitinib have good role in peripheral arthritis.
Sir, 5 minutes.
Okay. So this is the flow chart for the psoriatic arthropathy, and initially start with NSAID and local glucocorticoid, different GRAPPA, Euler and SCR criteria, and a few points regarding the reactive arthritis caused occurs after Campylobacter, Salmonella and Shigella infection, but you should remember again, as reactive arthritis is not synonymous with reiters. Again, another important thing is chikungunya arthritis, dengue arthritis, post-dengue arthritis are not reactive arthritis. They are definitely different entity, and they should be treated differently. And the reactive arthritis is usually mono or oligoarticular, low back pain in 44% patient. And in reactive arthritis, the eye changes are different, may present with conjunctivitis and episcleritis, and skin changes are aphthous ulcer, keratoderma, blenorrhezic and erythroderma norodosum, and mostly self-limiting. NSAID is enough with most cases with intraarticular and short courses of glucocorticoids, and but in few chronic cases, sulfasalazine is the first line of first choice, and followed by methotrexate. Very rarely TNF blockers is needed. And now rehab part. Physiatrists must try to support enhance their function, learn manage pain, fatigue, disease activity, loss of range of motion, reduce physical fitness. The European League Against Rheumatism has put the guideline in 2018, and which support the use of exercise therapy to help manage spondyloarthropathy. And this guideline support the notion that exercise is not only safe, but is integral, lifelong part of the care of, and that need to be promoted by all care professionals. Exercise are aerobic, strength training, flexibility, and neuromuscular balancing exercise. And non-pharmacological treatments have these parts: counseling of the patient, lifestyle modification, suitable recreational activity, posture care practice, joint protection, cognitive behavior therapy, and multimodal exercise program. What should we counsel? Explain benefit of daily exercises and physical therapy. Use NSAIDs and hot shower before exercise in case of pain and stiffness, and continuous exercise regularly throughout life. Lifestyle modifications: stop smoking and alcohol, control weight, and with an acceptable BMI, avoid falls, and good nutrition. And recreational activities important: walking, hiking, swimming, tennis, badminton, cross country, skiing, archery are good. Volleyball and basketball are excellent sports with AS patient. But sports activities which require prolonged spinal flexion, like golfing, bowling, and long distance cycling, are inadvisable. Body contact sports not recommended because of greater potential for injury, like football, basketball. And regular freestyle swimming is the most very good exercise, And posture care is very much important, and sleeping in regularly at least few minutes to few hours in prone position is good. And protecting the body, joint protection by proper transfer mechanism, lifting and carrying methods, positioning technique, posture awareness, training of maintaining pelvis and neutral position, basing and planning activities, and modification of activities and assistive devices if required. And cognitive behavior therapy, pain coping strategies, relaxation technique, and addressing the sexual problems. And all the modalities, physiotherapists are here, they can use all the modalities. Ultrasound therapy is very good, and apart from the other modalities also help, reduces pain and stiffness and contractures. And multimodal exercise programs aims relieve pain, maintain mobility of joints, prevent deformity, increase chest expansion, attention of posture, maintain and improve physical endurance. And I'm not going to details of exercise. The PG students will get this thing. You can do the and breathing exercise is very much important, like apical breathing, diaphragmatic breathing, lateral costal breathing, deep breathing, and incentive spirometry. And these are the different kinds of exercises which protocol exercises. Protocol here it's written. I'm not going into detail. And these are the exercise should be exercise and in different positions, sitting, lying down, and standing position. And there is not much role of orthosis. Joint spinal orthosis and cast base can be given to prevent spinal kyphosis. And safety is a very key consideration. Amount of bony changes and ankylosis, and because we should remember that patients may have osteoporosis and cardiorespiratory risk factor during doing exercise. And chronic exercises, yes, chronic review, Cochrane review of 11 trials of 763% shows home exercise program are better than no intervention. Supervised group exercise is better than home exercise. Regular home exercise with weekly supervised group exercise program have best outcome. Patients should be encouraged to do regular exercise even when disease activity is low, to utilize the window of opportunity to gain maximum mobility and fitness. Thank you. And it's a very vast topic. If anyone have any question, please.
We won't take any question now because we are running late slightly. Question and answer session can happen in the lunch break.
Thank you, sir. Our next lecture will be on the rheumatological disorder classification, which will be done by Dr. Jaydeep Nandi, Associate Professor in Department of PMR, AIIMS, Raipur. Over to you, sir.
Good afternoon, everyone. Before going into the lecture proper, that is rheumatological disorder classification, I would like to thank a few people personally for this conference. Identifying the disease, we can zero down into some differential diagnosis that may help in planning the investigations later on. For example, fever may be found in periodic fever syndrome or RA, like that. Hypertension may be found in vasculitis, muscular weakness may be found in myositis, and so on and so forth. And another important thing which can help in classification is the pain pattern, how the pain is presenting. When the patient is pointing towards a particular joint like shoulder or elbow, it is a natural tendency to think that it is that joint that is involved. But we are trained in such a way, we always think about the periarticular involvements also. So that is our strength, that we also identify the periarticular pattern of involvement. And there are fascial pain can happen also where the muscle is sore itself. Even every movement can be painful, even though the joint is not inflamed. So this is a way of identifying, zeroing down into the diagnosis proper. But there is another interesting method of classifying the rheumatological disorders. That is to classify the diseases into autoimmune diseases and autoinflammatory diseases. One of them is autoimmune disease is a disorder of the adaptive immune system, whereas autoinflammatory one is a problem of the innate immune system. So this is the classification that we can use in our day-to-day practice, and you can remember that almost all the medical branches also have this type of classifications, like neurosis and psychosis, like upper motor neuron disease and lower motor neuron disease, like anterior chamber problems of the eye, like posterior chamber problems of the eye. So most of the rheumatological disorders can also be classified. Most of them fits into that. But all said and done, like neurosis, psychosis, like human element, they are not hard and fast. They are not watertight. It is basically a spectrum of classifications. On one spectrum, there is the autoimmune disease spectrum, and on the other side there is the autoinflammatory spectrum. In between there is a mixed region, which is the MHC patches, MHC1 patches. So there can be rare monogenic autoimmune diseases which are very rare to found, but classic polygenic autoimmune diseases are very commonplace, like rheumatoid arthritis, SLE, AMCA-associated vasculitis, systemic sclerosis, dermatomyositis, like that. And again, rare monogenic autoinflammatory diseases are also very rare, as the name suggests. There can be periodic fevers, familial Mediterranean fever, like that. And there can be few acquired autoinflammatory diseases also, like adult onset steel disease, like systemic onset juvenile idiopathic arthritis. Polygenic autoinflammatory diseases can also happen, like IBD, inflammatory bowel disease, gout, sarcoidosis, like that. Now, what is the difference between these two diseases, or in fact the three diseases? The autoimmune diseases are quite common. They have a female predominance, and the age of onset is disease dependent. And regarding the therapy, B cell depletion DMARDs can be applied. Natural history is progressive, and usually they involve a single organ system. There are exceptions, but usually they involve a single organ system. Whereas the autoinflammatory diseases are quite rare. There is no sex predominance. It affects usually in the young patients, and you can give anticytokines as treatment in them. The natural history is recurrent, and there may be severe constitutional features, so severe that even it can be confused with sepsis also. These monogenic autoinflammatory diseases can be confused with sepsis also. And MHC1 patches are very rare. Here also there is no gender predominance, and it also affects the young patients. Regarding the treatment, it should be remembered that no B cell depletion is going to be beneficial in this MHC-pathies like ankylosing spondylitis or Beckett's disease. And the disease nature is waxing and waning. That should be remembered. Now we can classify the usual diseases into few examples which are classic autoimmune diseases, and few which are classic autoinflammatory diseases. Then we can go to few other examples like dermatodominant, like which are of the spectrum variant, where in the disease itself you can find some spectrum which is in the autoimmune category, some spectrum which are in the inflammatory category, like that. So rheumatoid arthritis, there is a recent criteria of SCR Euler of 2010, where large joints are usually given not too much significance. 2 to 10 large joints are only scored 1. And there is other thing which I won't be going into details. Moreover, it should be remembered that 6 out of 10 is the cutoff. And on the right side, I am showing a bar, red and blue, and the presence of the star indicates in the lower side that it is an autoimmune disease. Presence of the star on the above indicates that it is mostly an autoinflammatory disease, and the presence of star in the middle indicates that it is a MHC1 pathy. So there can be palindromic rheumatism also. Often we find that patients are RF positive, maybe ACPA positive also. Though they are not so much common like rheumatoid arthritis proper, but we can find that these patients are having joint pain, but that joint pain is very transient in nature. After few days or after few weeks, the joint pain is going on. Joint pain is vanishing, and there is no as such long-standing structural deformity that happens in the joint. So that is usually known as palindromic rheumatism. The palindrome word means the word starts with something and ends also with that same thing. For example, this is a very famous palindrome which is applied in almost every door of medieval Europe. This is said to be fireproof. Sator, Araco, Tenet, Opera and Rotas. Whenever you apply this in your door, there is no fire inside. So this is the characteristics. Classification of joints from RA perspective is very important. What are the large joints they consider? These are the large joints they consider, so they exclude wrist joint mainly. What are the small joints they consider, and what are they excluding while describing small joints? These are the exclusion of small joints, that is distal interphalangeal joint, first carpometacarpal joint and first metatarsophalangeal joint. There are other important diagnoses which can happen when these joints are involved. Now from the classic autoimmune, we are coming to classic autoinflammatory, which are monogenic in variety. So among them there is familial Mediterranean fever, there is mevalonate kinase deficiency, there are TNF receptor associated periodic syndrome. There is this is the diagnostic criteria given under the green heading, Eurofever criteria. They try to do away with the gene or genotype so that the classification can happen even when you don't have that facility. So presence of genotype and one criteria positive can be said to be positive for familial Mediterranean fever, or you can take two criteria also. And in case of TRAPS, you can take genotype plus one criteria or two criteria only if genotype facility is not available to you. And in case of MKD, genotype plus one criteria has to be taken. So similarly, there are also CAPS, also cryopyrin associated periodic syndrome, where genotype plus one criteria or two criteria can be taken. So there are also few diseases which are at crossroads, that is they are neither fitting into the autoimmune, neither fitting into the autoinflammatory, and these include spondyloarthropathies and Beckett's disease. Also they are nowadays referred mainly as MHC1 patches. The classification criteria Professor Parthapratim has well explained. I am trying to show a just animated thing. There can be a sacroiliitis arm on imaging, which requires another one SPA feature, or there can be an HLA-B27 arm, clinical arm, which should require another two SPA features minimum. And these features are shown here. There can be uveitis, there can be inflammatory back pain, there can be arthritis, there can be enthesitis, there can be dactylitis. 4 histories should be taken, that is history of psoriasis, Crohn's ulcerative colitis, good response to NSAIDs, and family history for SPA. 2 investigations are required, HLA-B27 and CR. So these are the SPA features, and you accordingly apply this criteria. And peripheral SPA ASS criteria, I won't go into details. Again, similar type of application of criteria. Now Beckett's disease, here mainly ocular lesions and genital apoptosis happens. Here the criteria is that you have to take 4 score as the cutoff mark out of 9 as the diagnostic criteria for Beckett's disease. Again, the presence of the star indicates that it is a disease which is lying in the crossroads, neither autoimmune, neither autoinflammatory. It is a MSC1 pathy. So now we will be taking example of some prominent immunological continuum model, where in the disease itself we will find examples where it is mostly in the autoimmune spectrum or it is in the autoinflammatory spectrum. So SLE is one of them. The recent criteria is the 2019 SER Euler criteria, where there is domains for constitutional disease, domains for other cutaneous features, arthritis, neurologic features, and like that. And overall, you take 10 out of 51 score as the cutoff, and in each of the domain, the highest score is taken as the score. You don't just add up all the scores, you take the highest score of each domain. And among the autoinflammatory continuum spectrum, continuum diseases, there is systemic juvenile idiopathic arthritis and adult onset Still's disease. This can happen after exposure to several external factors like infectious agents, some malignancies, or other environmental factors. It may activate innate immunity, immune cells through toll-like receptors, and then it will lead to abnormal responses, both innate and adaptive. That's why it is a continuum type of examples, and it is usually adult awkward inflammatory disease. Still's disease have a popular two criteria, Yamaguchi criteria and Fortrell criteria. Fortrell criteria has a benefit that it doesn't need exclusion of other important diseases. That's why it is very important. That's why it is very useful. So you need just 4 major criteria, 3 major plus 2 minor criteria. And Steele's disease as well as Sogia, they can be associated with macrophage activation system. As you know, it is a very life-threatening disease. It can be confused with sepsis also, bacteriological sepsis also. So the criteria here is HLH 2004 criteria, where 5 out of 8 score is the diagnostic. Now we will be discussing about few dermatodominant autoimmune disease and dermatodominant autoinflammatory disease. Dermatodominant autoimmune disease is systemic sclerosis. Here the criteria is based on scoring system. So 8 out of 24 is basically the cutoff criteria. And another dermatodominant autoinflammatory disease, psoriasis, is on the opposite side of the spectrum, where 3 out of 5 is basically the cutoff criteria. Now the vasculitis is again divided into both autoimmune as well as autoinflammatory groups. This is the Chapel Hill classification, where large vessel disorders are grouped into GCA, Takayasu and polymyalgia rheumatica, but it doesn't come into autoimmune, it comes under the autoinflammatory category. Medium vessels, medium-sized vessels and small and medium-sized vessels, they both come under this autoimmune varieties. Medium vessels include polyarteritis nodosa as well as Kawasaki disease. Small and medium-sized AMTA-associated include GPA, MP and EGPA. And there are small immunocomplex associated diseases like IgA, cryo and CL. Now, polyarteritis nodosa is small and medium-sized artery involvement. Score 3 out of 10 is basically the cutoff criteria. Kawasaki, the criteria is not given by ACL EULAR. The criteria is given by American Heart Association, because it is a significant disease for the cardiologists. So here the criteria is fever plus 4 out of 5 criteria is taken as the cutoff. Recently, or you can take also fever plus any major plus 2D ego findings. Now for the small and medium sized vasculitis, ACR EAR 2022 had came up with few criteria. They are very recent criteria, just came into being. Here also they are giving scoring systems. Few things are also taken as negative for these diseases, like the presence of in GPA. For example, 5 out of 17 is the classification criteria. But if blood eosinophil count is very high, then you will almost rule out, because -4 is given there. Or if there is positive test for P-ANCA, then you also almost rule out, because -1 is scoring there. Similarly, in microscopic polyangiitis, the score is 5 out of 12. Here also, the presence of nasal involvement is taken as a negative for microscopic polyangiitis, so score of -3 is given for that. So their presence make you rethink about your diagnosis. So 5 out of 12. Eosinophil granulomatous, this is again a ACR EAR 2022. All these things are recent additions into the rheumatology domain. So again here out of 14, 6 should be the cutoff criteria, and the presence of positive test for C-ANCA is taken as something which is not going with the diagnosis of eosinophilic granulomatosis. And also hematuria is also a negative point for eosinophilic granulomatous. And there are some autoinflammatory variant of vasculitis like polymyalgia rheumatica. The presence of the star indicates that it is in the autoinflammatory site. The presence of star in the below site indicates that it is an autoimmune disease. So here also 5 out of 8 is basically taken as a diagnostic criteria for polymyalgia rheumatica. And giant cell arteritis, 5 out of 25 is taken as a criteria for giant cell arteritis. Takayasu, 5 out of 19 is taken as the criteria for Takayasu. Skin and muscle dominant autoimmune diseases are there, but there is no scoring as such, that's only definition. There can be skin and muscle dominant autoimmune diseases like mixed connective tissue disorder, where Alarcon criteria quite old, 1987, but it is still found to be beneficial. Here, seropositivity for positive anti-E1 RNP at hemagglutinin titer of 1:1600 is taken as the serological criteria. We need, along with that, 3 other criteria. Or if 1, 2 and 3 is present, then also need 4 and 5 if serological criteria is not available. So there can be glandular involvement autoimmune diseases like Sjogren syndrome, where 4 out of 9 score is taken as a criteria, cutoff criteria. Relapsing polychondritis is basically a cartilage involvement autoimmune disease. Then finally, lymph node involvement, autoinflammatory diseases are also there, like sarcoidosis. Take home message from my lecture is that look for what is the symptom associated with when a patient is presenting with rheumatological disorders. Classify the pain properly. Look whether it is a joint pain, whether it is a periarticular pain, whether it is a fascial pain, neuropathic pain. That will help in identifying the diagnosis. Divide between autoimmune and autoinflammatory according to adaptive or innate immunity involvement. One is usually organ-specific involvement, another might lead to sepsis-like pictures, and severe blown-out systemic involvements. And you can broadly divide the total diagnosis of rheumatological disorders into classic variants, continuum variants, dermatodominant, vasculitic group, skin muscle dominant, autoimmune, gland cartilage dominant, autoimmune and lymph node dominant, autoinflammatory. This might be beneficial for remembering and recapitulating. So thank you everyone for your patient listening. Over to you.
Thank you, sir. Next, may we have on dais Dr. Chethan C, Assistant Professor, PMR Department, ABP IMS and Dr. Aramal Hospital, New Delhi, to speak on the topic bony diseases, osteonecrosis, Paget's disease, osteomalacia, etc. Welcome, sir.
Thank you. Good afternoon all. So I'll be speaking on bone disorders. So they have given me 3 topics. So I'll be speaking on these 3 topics. I will be elaborating. So those 3 topics are very huge topics. So I'll try to cover that in this 20 minutes. So firstly, we'll speak about the calcium hemostasis. So the main 3 hormones which are involved are parathormone, vitamin D and calcitonin. So parathormone basically it activates osteoclast, so leading to increase in calcium absorption and activation of vitamin D3. Vitamin D, it basically increases the absorption of calcium, thus decreasing the level of parathormone. Calcitonin, it helps in decreasing the concentration of plasma calcium. So to summarize, parathormone and vitamin D, they act to increase the plasma calcium. Calcitonin causes decrease in plasma calcium. So coming to the bone remodeling, so we have Minal sir was speaking about the hematopoietic stem cells. So when we in process of reabsorption, the hematopoietic stem cells, they are activated into pre-osteoclast. Then we have this receptor, the Ranker receptor, cathepsin receptors. This is where in osteoporosis we target these receptors. So this leads to osteoclast, they transform into osteoclast, that leads to bone remodeling. Then the macrophages come in and these are observed. Then mesenchymal stem cells are activated. This leads to formation of osteoblast, which lay the osteoid, which becomes mineralized by bone lining. So this is the process of remodeling of the bone. So these 3 diseases which we are speaking about is an alteration of this mechanism. Coming to Paget's disease. Paget's disease, will be speaking about Paget's disease of bone. It is a non-malignant, it is a skeletal disorder where there is abnormality in bone remodeling. How does it happen? The pathophysiology is there is increased number and activity of osteoclasts and it is coupled with increased osteoblastic activity. So what happens? There are 3 phases. In the lytic phase, there is increased abnormal osteoclast activity which leads to excessive resorption. And in the next phase, there is resorption and pronounced osteoblastic activity. So both mixture is happening. And in the sclerotic phase, because of this mixed match, so the bone form it will become weak. So there are certain risk factors, especially increasing age. It is known to be more common in 4th and 6th decade, especially between 50 to 55. Male gender is predominantly affected. The ethnic background is, the literature says the European population has more predominance for getting Paget's disease, especially the UK population. And there are certain genetic factors which are involved, specifically the mutation of SQH-ST1 gene and certain environment factors where there are they have found that there are certain viral infection which leads to activation of this mutation and leads to Paget's disease. So the clinical presentation is, because the calcium metabolism is altered, so there is a varied presentation. But we are speaking about the Paget's disease of bone. So in musculoskeletal, what happens is there are bony deformities, bone fractures, bone pain is the most predominant presenting symptoms. Because of abnormality in the bone, there are certain deformities which leads to spinal canal stenosis, which can lead to para or quadriplegia, and in skull deformities there might be basilar invagulation and can cause quadriplegia. The other most dreaded complication is this Paget's disease turning into neoplasm, especially osteosarcoma. How do you assess a patient with Paget's disease? So the diagnosis is based on clinical presentation. Then the most important factor is elevated alkaline phosphatase level, especially the bone associated ALP and certain radiographic features. The pathognomic features of Paget's disease in a plain X-ray are osteolytic areas, cortical thickening. So you can see there is cortical, it doesn't project on the right screen. So this, okay, pointer I will. No, I won't. So you can see there is trabecular thickening, so you can see the bony expansion, so then that leads to deformity. Bone scintigraphy, you can see the uptake because there is increased osteoblastic activity, you can see there is increased uptake in the osteoblastic region. Biochemical analysis, as I said, bone specific ALP is increased and the bone turnover markers P1P and NTX are elevated. On histopathology, we can see there is irregular broad trabeculae and there is profound bone resorption which is found on histopathological analysis. Coming how to go through the assessment, I am just summarizing it. So when there is genetic predisposition, environmental factors, exposure, the pathophysiology as explained. So that leads to increased serum burn markers of the bone resorption. Then there are lytic lesions in the bone, skeletal deformities. All this leads to bone film or deformity. So how do you treat this? Paget's disease, 95% of patients are asymptomatic. When patient comes with symptoms, which is 5%, so we assess for bone pain, presence of any headache due to skull involvement, back pain because of spine involvement, any fractures, or if there is hypercalcemia. If all these features are present, treat with bisphosphonate, especially zoledronic acid is preferred. So what is the dose? Zoledronic acid is the first line of drug. It is given in a dose of 5 mg over 15 minutes. The effect is known to last for 6 years. There is no need to inject zoledronic acid again till 6 years. We have to just monitor. The other bisphosphonate recommended are residronate and alendronate. There is controversy of prescribing calcitonin and denosumab because after cessation of these drugs, the biochemical abnormalities recur, so it is still under evaluation. So we have to monitor this. Once the treatment has been given to the patient, we have to see the extent of skeletal involvement. So what is the extent of skeletal involvement? We have to see the entire affected body, specifically the plain X-rays of abdomen, pelvis and skull. Or else if these features are not present, if you want to see a widespread spread of Paget's disease, we can get a bone scintigraphy if patient can afford and monitor. If there are fractures, we treat them with ORF and internal fixation and bisphosphonate. How to monitor? Monitor the serum ALP level, which is the first investigation. It has to be repeated 3 months after the bisphosphonate therapy and later on after 12 months. We have to monitor the vitamin D level and look for bone turnover markers, decrease in this bone turnover markers. Coming, the second disease is osteonecrosis. What is osteonecrosis? I will be speaking only about osteonecrosis of femoral head because osteonecrosis it can affect jaw, it can affect talus, it can affect knee, it can affect shoulder, humeral head. So what happens in osteonecrosis? It is typically characterized by death of cellular components of the bone and it affects the epiphysis of long bone, especially the weight bearing joints. Hip is the most commonest location, so we will be discussing about the osteonecrosis of femoral head. It typically affects the young active 20 to 40-year-old population, which results in substantial loss of function because they are active in this young age. There are two pathways described in the literature. One is a traumatic pathway, the other is a traumatic pathway. What happens in traumatic pathway? There is a hip fracture or dislocation. This leads to interruption in the blood flow, which leads to a critical ischemia leading to bone necrosis. There is an inflammatory response which leads to bone resorption and collapse. In atraumatic, there are so many risk factors described like glucocorticoid intake, alcohol intake, sickle cell disease, many inflammatory arthritis and coagulopathies, certain drugs. This leads to adipocyte hypertrophy, which in turn leads to endothelial damage and thrombus formation. This in turn leads to critical ischemia and lead to bone resorption and collapse. So how does osteonecrosis of femoral head present with? Usually it is in the initial stages, it is asymptomatic. So when patient develops pain, there might be pain in the hip region which might radiate to the knee, and on physical examination during initial presentation there might be limitation of range of motion, and they might particularly complain of pain during internal rotation. As the disease progresses, the pain increases, the range of motion decreases, and patient will have difficulty in walking. How to evaluate? So the most sensitive test to pick up osteonecrosis of femoral head is MRI. It has around 95% sensitivity. What are the findings we see? We see reactive interface line, this serpentine lines. This is known as double line sign. There will be diffuse edema, and in the later stages there will be collapse, which looks like an osteoarthritis. Coming to the second most sensitive test is bone scintigraphy. It is 85% sensitive, and when there is multiple site involvement, it is the investigation of choice. In early disease, because there is decreased vascular supply, it presents as a cold spot, and in later disease there is something known as donut sign. What is this donut sign? There is a cold spot and there is surrounding hyperemia. So there is an increased uptake. So it presents as a donut sign. In recent advances, we can do representative DSA imaging with micro CT, so we can see how the disease progresses. As the disease progresses, the amount of vasculature in the femoral head decreases as it reaches the late phase, and there will be osteonecrosis. On plain radiograph, initially the findings, there are no findings, but in later stages we get something known as crescent sign. You can see this. There is collapse of the subchondral bone, so this leads to this crescent sign. And in the later stages, there is osteoarthritis which is set in, so there is complete collapse and ankylosis of the joint. There are various classifications for osteonecrosis of femoral head. ARCO classification is the recent one. There is flat classification, there is Japanese classification, but ARCO classification has both clinical and radiological, so this is widely used. So there are 5 stages in ARCO classification. In stage 0, the radiograph is normal, the MRI is normal, there are no clinical symptoms. In stage 1, the X-ray is normal, but there are some abnormalities seen on the MRI. So what happens? So the disease is set in. So here the patient might present with no symptoms, or they might be presence of some mild pain. In stage 2, we can notice changes in the plain radiography also. So you can see the trabecular changes within the subchondral bone. So the disease is progressing further. As you can see here, so the disease is progressing further. MRI also is abnormal, and the symptoms will come in picture. So in stage 3, it further worsens. The trabecular bone changes and there is subchondral fracture. So there is this crescent sign. So the disease progresses further. Depending on the depression, so we classified it into type 3A and type 3B. In stage 4, so the disease has progressed completely. So there are features of osteoarthritis, and you can see distorted femoral head. So how to approach a patient with osteonecrosis of femoral head? In patient who has high risk group, so get a X-ray done. If the plain X-ray is, if you are suspecting, and because in the initial stages, X-ray is not a good sensitive test to do, usually it turns out to be negative. So if there are features, yes, you can proceed. If there are no features, MRI is the sensitive test, so get MRI of bilateral hip joint. So if it is inconspicuous on MRI, so follow up. Then if it is positive, we classify according to ARCO classification. So in stage 1, as we discussed, there is no pain, or there might be pain, and further we can start the therapy. So what are the treatment proposed for femoral head? There are non-surgical treatments and there are surgical treatments. In surgical treatment, protective weight bearing, which helps in avoiding impingement and impact loading activities, usually done with crutches. The literature doesn't support about using of orthosis like weight relieving orthosis. The pharmacological treatment are to maintain the blood supply, especially anticoagulants like enoxaparin. It has known to increase blood flow and decrease the ischemic area. Vasoactive agents like prostacyclin, this helps in improving the blood supply to the femoral head. Bisphosphonate, alendronate is the prescribed drug as per literature. What it does is it significantly reduces the incidence of collapse. Lipid reducing agents like statins, especially in patients who are receiving steroids. Biophysical treatment. So this is one interesting part of the biophysical agents. We use ESWT for pain management. So ESWT is known to restore tissue oxygenation and reduce edema. This helps in inducing angiogenesis. This improves the pain and function in patient. Pulsed electromagnetic therapy. This is also known to stimulate osteogenesis and angiogenesis. HBOT therapy. So in the morning we saw about HBOT therapy for neurological conditions. HBOT therapy, there are certain literature review which says because of the increase in the extracellular oxygen concentration, it reduces cellular ischemia and in turn helps in increasing the blood supply in the femoral head. And individualized structural rehab, because in various stages present with various symptoms, so we have to do a structural rehab in each stages. For pain management, certain interventional pain management are also proposed, like neural blocks, the articular branches, and articular branches radiofrequency ablation. The surgical treatment options. So currently there is no consensus on what surgery has to be done depending on the different stages of the osteonecrosis. Total hip replacement is the most common intervention for the treatment of collapse of osteonecrosis of femoral head. The second most commonest thing done is core decompression. So there are other less frequently used treatments: vascularized or non-vascularized bone grafts, ME orthoplasty, osteotomy, and orthodesis. So in the recent advance, we have cell-based therapy and scaffold-based therapy. In cell-based therapy, bone marrow-derived mononuclear cells or mesenchymal cells, when they are doing the core decompression, these are directly injected into the femoral head. Even PRP has also been tried, but there is very less evidence regarding this. In scaffold therapy, again these exomes are put in a ceramic-based scaffolds or polymer-based or hydrogel-based scaffolds, and they are put into femoral head. This has been known to increase the angiogenesis and osteogenesis, which leads to improvement in the blood supply in femoral head. This is to summarize. If patient has pain, so get an X-ray or MR. If there is none, we'll get an MR. On stage 1, we observe and bisphosphonate is recommended and various surgical treatment. In stage 2, bisphosphonate with surgical management appropriate to the stage. In stage 2B, same thing. So and when there is stage 4, the preferred mode of management is total hip arthroplasty. So we have to look into prevention, because we see a lot of osteonecrosis femur in our OPD and we prescribe steroids, and especially when we deal with patients who have acute fracture. So in case of traumatic osteonecrosis of femur, we have to ensure that the blood supply to the femoral head is maintained. It can be by anastomosis or bone flaps or vascular pedicles. In steroid-induced patients, the literature supports use of vasodilators, which is combined with anticoagulants. Especially ecosprin is preferred with statins. Coming to the last topic, osteomalacia. It is a disorder of defective mineralization of newly formed bones. So what is the difference between osteomalacia and rickets? In osteomalacia, there is defective demineralization of a bone turnover, but in rickets, it is in the epiphyseal growth plate. Can osteomalacia and rickets appear in the same patient? Yes. When we have open growth plates, initially there will be rickets, and when there is fused growth plates, so there will be osteomalacia because of the vitamin D deficiency. So what is the cause of osteomalacia? Vitamin D deficiency is the most commonest cause, followed by calcium and phosphate deficiency. What happens because of demineralization or impaired mineralization? There is weakening and softening of bones. There are 3 stages. In initial stage, there is normal calcium level, there is elevated ALP and serum parathormone. In second stage, the serum calcium and phosphate level decline. The PTH and ALP further increases. Vitamin D can return to normal or low. In final stage, there is hypocalcemia and hypophosphatemia. The symptoms are usually, we see in our OPD is proximal muscle weakness, myalgias, difficulty in walking, especially waddling gait, spinal deformities, and there is risk of increased fall. If there is hypocalcemia, patient can present with tetany. So the investigations, how to go about investigating the patient. So on plain radiograph, we can see looser zones, especially in the femoral cortex, pubic rami and scapula, fractures, you can see those fractures, biconcave vertebral bodies, triradius pelvis with protrusio ostabile, and in bone scan we can see increased state outspots. So to summarize, there are two, vitamin D deficiency and phosphate deficiency. We have to differentiate because appropriate therapy has to be initiated according to the cause of osteomalacia. So the difference is when you see phosphate deficiency and calcium deficiency, so the serum parathormone is normal in phosphate deficiency, but it is increased in vitamin D deficiency. That we have to keep in picture. So there is this Japanese criteria to diagnose osteomalacia. So if there is presence of all five, it is definite osteomalacia, and if number 1 and 2, which is hypophosphatemia, hypocalcemia and elevated ALP, plus the other three, any two of the other three, muscle weakness or BMD less than 80 or looser zone or Milkman fracture, we diagnose it as osteomalacia. So the treatment is, the goal is to elevate symptoms, to promote fracture healing, to restore bone strength and improve quality of life while correcting biomechanical abnormalities. So there is a global consensus on how much vitamin D has to be given to the patients. In infants, usually the prescribed limit is 2000 international unit for 12 weeks. For 12 months to 12 years, it is 3000 to 6000, and for more than 12 years, it is 6000. And accordingly, we have to supplement with calcium also, and the maintenance dose is 400, 600 and 600 respectively. So we have to supplement vitamin D, not just giving vitamin D as a treatment modality. So there are various modes to supplement it. It can be fortification of the food or biofortification. This is engineering the foods so that it is fortified, and you can do a combined approach. So word about tumor in my last slide. So a word about tumor-induced osteomalacia. We encounter this commonly in our OPD because the incidence of cancer has increased. So here what we have to see is, this is because of phosphate deficiency. So we have to assess the phosphate level and supplement with oral phosphate. Usually it is given in 1 to 3 grams per day and divided into 4 to 5 doses along with vitamin D. There is a recent advance of monoclonal antibody called Urosumab, usually prescribed in dose of 0.5 mg per kg every 4 weeks, which can be increased. So can I have 30 seconds? Thank you. I am just showing this. So this was one of our patients we injected in osteonecrosis of femur. We did this pen block. So here what we did is, they say he was getting femoral nerve block elsewhere. So we went to the literature and we found that pen block is better than femoral block. Here, because the articular branches of the anterior capsule of hip joint from obturator and femoral nerve, they accumulate here. So we can use this pen block in interventional pain management of patients with osteonecrosis of femur. Thank you.
Next, we would like to listen to Dr. Kumar, Associate Professor and HOD of PMR in IGIMS, Patna, to talk on the topic, role of UST in rheumatology.
Correct, in this university I have present additional professor. Dr. Kumar is additional professor.
Additional professor. Happened after CD slide is made. So it shows the long-term planning of our residents. We planned it 2 months back.
Okay, good afternoon everyone. I'll be speaking as well as sharing my 15-year experience of use of ultrasound in musculoskeletal medicine. Okay. So, in musculoskeletal medicine or rheumatology, meticulous history and clinical examination is the most important thing. That will solve more than 90 to 95% of the patient. And for us, ultrasound is not an investigation. It's a part of clinical examination. So I will be presenting in the same week, it will act as a clinical examination or extension of the physical examination. Okay. So when we focus on the history, main three things related to will be very much important: history and clinical duration, number of joints, and diseases inflammatory or infective or neoplastic or any other thing. So let's understand the disability in case of, for example, in case of rheumatoid arthritis. So you know that pathology lies in the synovium that causes synovitis, tenosynovitis, bursitis. So we will able to detect it as a preclinical RA or early RA, as like we will able to detect synovitis, tenosynovitis, bursitis and other things. And this pathology will cause disease like rheumatoid arthritis. So we will able to assess the disease activity, or we will able to assess the response of the treatment in case of RA through the ultrasound. And impairment due to disease, suppose patient is having pain or not able to walk, and pain, we can address pain with the ultrasound guided medication. So for disease especially, this slide is very important for any disease, any disability. This is very important to understand at what level, what type of intervention and what options we have. So these are the confirmed uses of ultrasound. It is used in the early diagnosis of RA, as I told, diagnosis of synovitis, tenosynovitis, bursitis, or sometimes a decision on the possible change of therapy. As we published in the our Indian Journal of Physical Medicine and Rehabilitation topic, musculoskeletal ultrasound, the physiatrist third eye, we showed 6 case series that shows how ultrasound will has changed the treatment protocol for that patient. Okay, and it also helps in the injection decision. And doubtful usage is its monitoring of aggressive treatment to treat target to treat treatment strategy. It's a doubtful outcome in case of. So it's not a new thing. Musculoskeletal ultrasound, it is being used for the last 30 years. And when one conference of American College of Rheumatology occurring in 1997, one question was asked to the renowned, at the time renowned musculoskeletal radiologist, what are the uses of musculoskeletal ultrasound in case of rheumatology? He answered, only Baker's cyst. So that is in 1997 Baker's cyst, though it was used since Baker's cyst was reported to be diagnosed by the ultrasound since 1984, I think. But after that, in 2006, Euler started it at the different level. And in 2014 in Delhi AIIMS, we organized a workshop. And since from north to south, we have seen many workshops for the diagnosis, interventions going on as a training program. So let's see the basics of how ultrasound machine works. Through the electric current, piezoelectric crystal is activated that releases ultrasound wave, and that differentially absorbed through the various body organs and then reflected back from the bone, where it is processed and we show the image in our screen. Okay. And we know the higher frequency has shorter penetration and lower frequency has long penetration. Okay. So higher frequency has good resolution of superficial images, and lower frequency has poor resolution of the superficial images. Okay. And let's identify when we start. Let's identify these structures. In the case of like shoulder, this is the skin. This is the deltoid muscle in cross section, showing steady sky appearance, and this is the tendon in cross section, showing boom-end appearance, or in longitudinal section, it's fibrillar or lamellar appearance, and this black is the cartilage, and this hyperechoic white line is the bone. And in musculoskeletal ultrasound, correct angle is very important for the measurement as well as to avoid the anisotropy. When structure is perpendicular to the tendon, then it will get image like hyperechoic. But when it is not perpendicular to the tendon, we will get it as a hyperechoic biceps absent. But beginners will mistaken it as, but experts will utilize anisotropy in various diagnostic processes. just going through the small this structure to identify this is longitudinal images of the supraspinatus tendon. This is the deltoid. This is the supraspinatus tendon, and this is in the cross section. And we have to identify tendon. What is the characteristics of tear in the ultrasound? Like most of the tear will be anechoic. We can see this is the tear of the supraspinatus. This black is the anechoic. It is well defined. We can see it is almost well defined. Homogeneous, thin. We can say the structure in normal. This is the normal thickness of the supraspinatus. Here it is a loss of contour and become thin. Insertional supraspinatus tear. And bony irregularity. We can see here. This is bony irregularity. And tendinosis is a tendon has become thick. We can see here tendon has become thick. It's a mixed heterogeneous appearance, hypoechoic combined with the hyperechoic images, and it will be ill-defined. You can see this is in the cross section, this is in the longitudinal section, and but cortex will be smooth in case of tendinosis. These are basic things to understand. And calcific tendinitis is very common, and it may be picked earlier than the MRI in case of ultrasound. This X-ray, these things doesn't require ultrasound, but this type of images are even lighter than this type of images. It will be better picked with the ultrasound, and even sometimes better than the MRI also. And this is subacromial subdeltoid bursa. This is huge accumulation in subacromial subdeltoid bursa. And in ultrasound examination, tendons, all extensors like wrist is the basic things to examine, because in all inflammatory arthritis, tenosynovitis associated occurs, and sometimes it may be first presentation of inflammatory arthritis also. Extensors as well as flexor tenosynovitis, both. This is the flexor tenosynovitis of the flexor digital tendon. This is the synovial fluid accumulation. This is the synovitis part, and erosion. Ultrasound also detects the bony erosions, but it should be confirmed with the both longitudinal as well as the cross sections. And other than the upper joint flexor and extensor tenosynovitis, in inflammatory arthritis, ankle tenosynovitis are also very common, but usually patient reported first there is problem in hand. If they is not able to walk, then they will say there is problem in ankle. So ultrasound helps in the early detection, grading, and treatment of the synovitis. And this synovitis has both like grading. It has a graded 0 to 4 scale on gray scale image, as well as like color Doppler images also. So in ultrasound, in this way we will able to see the whether synovitis has decreased, increased. So we can also see the monitor or see the progress of these things. And joint diffusion, that is the very important thing and basic things to detect, and it occurs very early in the case of rheumatoid arthritis. And we all know that it appears anechoic, and it will be displaced, but synovitis will not be replaced. And a small joint diffusion, you can see this is reported well back in 2002. Ultrasound detect a small joint diffusion, and sometimes clinically we miss this small joint diffusion. And this is the classical rheumatoid pannus. We are able to detect this pannus also with the help of musculoskeletal ultrasound. So this musculoskeletal ultrasound, if we add in the 2010 ACR regular criteria, it will help in the detection of the counts of the, like we will able to spot better in case of rheumatoid arthritis. And ultrasound, there are so many patients will not fit in the like clinical, when the ACR regular 2010 criteria will not, patient will not fit. But with the clinical acumen and variety of presentation, ultrasound is really very, very helpful in diagnosing those cases. This will see these are the flexor tendon. You can see here this is the flexor tendon tenosynovitis in this case. And when flexor tendon involved, it will like most of the patients present with the symptoms of the carpal tunnel syndrome. So evaluation of this carpal tunnel area is very important to understand what kind of pathology compressing this median nerve. it's a not a diagnosis. So I'm just showing you a clinical case. This is a 33-year female come to me with this picture. All inflammatory markers are negative. Hemoglobin 11.7, ESR 22, anti-CCP rheumatoid factor all negative. Even CRP is also negative. But patient presented with almost bilateral hand pain. Patient went to many neurologists, many other rheumatologists also. When he examined ultrasound, it was this is the flexor tenosynovitis compressing the median. Since all tests were negative, nobody was considered it may be a case of early arthritis. If you treat those cases, then only you can prevent the disability. So our job is to diagnose and treat those cases. So I will show you this patient also has a small joint effusions also. Although patient I couldn't able to see the erosion in the ultrasound. Even since patient was a high profile, patient was a civil servant, and patient's husband was also a big official in the university. So I also done the MRI, and MRI described the same finding: bilateral asymmetrical synovial thickening of this first metacarpal phalangeal carpometacarpal joints, second metacarpal diffuse reduction in joint space, okay, diffuse synovial sheath thickening, mild inflammatory changes, evidence of medianal compression on the other side, and these findings are suggestive of rheumatoid arthritis. And asked, because I am having doubt, the patient may be a case of tuberculosis also. Sometimes we don't get other like serological marker positive in case of tuberculosis also. I started the treatment and we have got very good response in this case. And another patient, like 33-year female, he was already on treatment from the AIMS Rheumatology department, DMARS, and he was having complaint of the carpal tunnel-like pictures. All investigations suggestive carpal tunnel syndrome, and neurologists advised carpal tunnel spleen, but he was not having relief. When we examined through the ultrasound, so you can see this is the median and this is the ganglion compressing the median. So when splint was given in the extended position, this ganglion was going in the carpal tunnel, causing more pain. So we can also advise orthosis accordingly to help in the suggesting the orthosis. And when we treated this ganglion, as I symptoms of the relief. This is already published in our journal. And shoulder pain is very common in genetic age group. That's why I'm telling you, it's always should be combined as a part of clinical examination. Because patient coming with the right shoulder pain will see the right shoulder pain has less tear and left shoulder pain has more tears. But that is asymptomatic. Those asymptomatic shoulder pain should not be treated at all. Because it's not limiting the function, especially in the genetic age. So it is the same patient. Patient has a complete supraspinatus tear, you can see, but patient is totally asymptomatic. We will treat only affected side. That is the message. And USG is very also like helpful in the diagnosing and characterizing psoriatic arthritis, especially microinthesophyte. In psoriasis, detection of microinthesophyte is very important, as well as this paratendonitis, inflammation of the extensor tendon. These two are characteristics in the case of psoriatic arthritis. And in case of ankylosing spondylitis or any peripheral presentation of spondyloarthropathy, this distal Achilles tendinitis as well as enthesitis are very common, and it is very easily detected by musculoskeletal ultrasound. And in gout, we know that musculoskeletal ultrasound is already included in the guidelines classification criteria for the gout. This double contour sign is the characteristics of the gout. And in chondrocalcinosis, calcification occurs within the cartilage. We are able to, so even it doesn't require synovial aspiration and like crystal viewing of the crystal under the polarized microscope to identify these cases. So through non-invasive method we are able to detect this. So let's summarize the things we have discussed. Like If there is synovitis and erosions are symmetrical tenosynovitis, most likely we are dealing with the rheumatoid arthritis. And if there is asymmetrical depression, double contour signing, or there is hyperechoic aggregates inside the joint or tophi, we are dealing with the gout. And if there is chondrocalcinosis or TFCC or menisci calcification of the capsule or other joints, then we are dealing with the CPPD. And if there is synovitis but erosion are sparse, maybe we are dealing with the connective tissue diseases or overlap symptoms. So, if patient is of age than 50 complaining of shoulder, hip pain and ultrasound, we are detecting the mild subacute of deltoid bursitis, and there is no synovitis in MCP PIP as well. Most probably we are dealing with the polymyalgia rheumatica. And if there is enthesitis, inflammation of palmar plate, collateral ligament synovitis, tenosynovitis, soft tissue edema, peritonitis erosion, we are dealing with the types of the spondyloarthropathy. And if there is high suspicion of infection or there is subcutaneous edema with positive Dopplers and culture is positive, we will be dealing with the septic arthritis. And if it is in knee, there is distal extension and with the negative Doppler sign, we are maybe dealing with the rupture of the Baker cyst. This is the Baker cyst. It is showing communication with the joint. It is showing needle aspiration of the Baker cyst. Okay, and this was 65-year-old patient of the osteoarthritis patient coming with the acute cellulitis like picture of the lower leg. We examine, we see this collection is extending distally till near almost up to the mid calf. Okay, this is the medial gastrocnemius, and there is subcutaneous edema typical like of cellulitis like picture, common stone like picture, but this was not a case of cellulitis. This is a case of just rupture of Baker cyst. We give with conservative management, patient will improve and will avoid unnecessary cost of various investigations, which otherwise we have been asked for. And just for the sake of completeness, you can see in progressive systemic scolitis, we can see this blue line represent skin thickening, and if other findings are esclosing tenosynovitis, soft tissue calcification, we can also detect through the lung ultrasound. This is the halo sign in the case of giant cell arthritis. This is a case of Takashima arthritis, showing macro-knee sign in longitudinal section, cross section, and this is contrast enhanced ultrasound showing microbubbles that shows the disease is active. This is the salivary glands. This is the normal, and these are abnormal salivary glands detected through ultrasound. Okay, so ultrasound is very useful guided intervention. When we are not using, we see we are best in injection, our techniques are good, but most of the studies shown those who are expert also, 2/3 of the shoulder injection they are depositing superficial to the joint. So ultrasound definitely improves the accuracy. And these are the criteria where we should do the ultrasound guided intervention if we are not using regularly. And these are the two techniques: in-plane technique, out-plane technique, and these are various kind of ultrasound guided intervention. Okay. Just for the sake of completeness, I am showing. So, in case of ultrasound is helpful in large vessel vasculitis because it is easily accessible compared to biopsy and immediate application in outpatient clinic. In systemic sclerosis, skin involvement, inflammatory myopathy also, because it helps in guided biopsy also, the open biopsy can be avoided. In ILD also, it can be used as a screening tool. In primary Jordan syndrome, this non-invasive investigation will give you a good idea about the disease. And these are the advances of the other ultrasound, like 3D ultrasound, contrast enhanced ultrasound, sonoelastography, okay, super microvascular imaging, fusion imaging. But fusion imaging, we have to fusion with the MRI or CT, that requires more cost. But these are the recent advancement in this, and other recent advances, 3 and 4 dimensional ultrasonography will able to correctly grade the size in 3D how much tear, what is the size, leaf retraction, everything we are able to see with the CME. So I conclude with these things, and I can see the future. Like the doctors is known with the stethoscope. Similarly, we will be like known by our musculatory ultrasound. It will be act as our stethoscope, as well as pain, which will in future we'll see that we'll keep our ultrasound machine like pain in our pocket itself, and we'll see images in our mobile. Thank you.
Before breaking for the lunch, let's have a short felicitation ceremony. May I invite Dr. Kumar